Hi, I'm Lauren Stimson. I'm a current orthopedic surgery resident. I'm also a former paramedic of Williamson County Emergency Medical Services. This is a research collaboration between myself and Dr. Jeffrey Jarvis, who is the current medical director of the Metropolitan Area EMS Authority in Fort Worth, Texas. For our investigation, we performed a retrospective chart review on the pre-hospital administration, meaning the administration of medications given in the field by paramedic providers, the pre-hospital administration of ketamine versus two commonly used opioids, those being morphine and fentanyl, for the management of acute pain following traumatic injury. This topic has been of particular interest to us because although opioids have really been the mainstay of treatment for the management of acute pain by EMS systems, there has been an increased focus over the past couple of years for the use of ketamine as an alternative to opioid treatment for pain management. So as a brief overview on some of the properties of ketamine, it's thought to exert its pain modulation mostly through a dose-dependent non-competitive antagonism of the NMDA receptor via binding to the receptor's phencyclidine site in the central nervous system, as ketamine is a derivative of phencyclidine. It exerts its analgesic properties by inhibition of that NMDA receptor. It has a slow off rate, so this results in a prolonged receptor blockade and sustained analgesic effects. Other mechanisms of action in reference to ketamine's pain modulation are thought to include, but certainly not limited to, the direct binding of opioid receptors, cholinergic receptor antagonism, blockade of sodium and potassium channels, activation of D2 receptors, and facilitation of GABA signaling, although these pathways are not as commonly described. It's worth noting that when ketamine is used for pain management, the dosages are lower than those used for procedural sedation or anesthesia. In this context, the terminology is commonly, quote, low-dose ketamine or, quote, sub-dissociative ketamine. There's not a clear guideline for the exact milligram per kilogram amount that constitutes low-dose ketamine. There's several references in the literature. I've listed some on the slide just so people can get an idea of what those dosages look like. For example, a paper out of George Washington University considers an IV bolus of less than 1 milligram per kilogram as subdissociative. So the question that we had was, how effective are these subdissociative doses of ketamine when compared to traditional opioids for the use in acute pain management? So the purpose of our study was to compare the analgesic effects of low-dose ketamine versus morphine, as well as the analgesic effects of low-dose ketamine versus fentanyl for the treatment of acute traumatic pain in the out-of-hospital environment or in the pre-hospital environment. We did so via a retrospective chart review of all 911 calls answered by 887 consenting EMS agencies over about a one-year period between January 2017 and December 2017, in which patients were treated either with low-dose ketamine or fentanyl or morphine. We considered a dose of less than 1 milligram per kilogram as low dose. Many of our charts did not have weight documentation, so we assumed that the average adult to be between 75 and 85 kilos, and therefore any dose of less than 70 milligrams of ketamine would be considered low dose. We included patients greater than 13 years old with pain secondary to traumatic injury, an initial pain score of greater than or equal to 5, and at least one documented subsequent pain score who received either low-dose ketamine or morphine or fentanyl. We excluded patients less than or equal to 13 years old who had an initial pain score of less than 5 and received greater than or equal to 70 milligrams of ketamine. We had a total of 35,906 patients. 1.8% received ketamine, 80% received fentanyl, and 18.2% received morphine. Mean ages of ketamine, fentanyl, and the morphine group were 49.8, 57.2, and 56.9, respectively. Median single drug dose of ketamine, fentanyl, and morphine groups were 15 milligrams, 50 micrograms, and 4 milligrams, respectively. The median total dose is also listed in the chart. Our primary outcome was defined as the proportion of patients in each group with a clinically significant reduction in pain from pre-medication to post-medication on the numeric rating scale. We defined a clinically significant reduction in pain as being a decrease in NRS of greater than or equal to 1.3 from the first documented pain score to the last documented pain score. This number of 1.3 was taken from an observational perspective cohort study of patients presenting to the ED, in which the authors determined that a change in pain score of 1.3 on the NRS was the minimum change reported to have a clinically significant impact. Our secondary outcomes were the median and interquartile ranges for change in Glasgow Coma Scale, pulse oximetry, end-tidal CO2, systolic blood pressure, heart rate, and respiratory rate from pre-treatment to post-treatment. For the primary outcome, the first column displays the mean and confidence intervals for the proportion of patients in each group that had at least a 1.3 decrease in pain on the NRS. In the ketamine group, this proportion is 84.8. In the fentanyl group, it's 85.8, and in the morphine group, it's 83.6. The third column shows the difference in the proportion of patients with clinically significant reduction in pain, and the fourth column, of course, shows the p-values for these differences. We found there was no significant difference in the proportion of patients with clinically significant pain reduction when the ketamine group was compared to the morphine group, or when the ketamine group was compared to the fentanyl group. We did, however, find a significant difference in the proportion of patients with clinically significant pain reduction when the fentanyl group was compared to the morphine group. In conclusion, this was our retrospective chart review of 887 EMS agencies and 35,906 patients. There were no significant differences in the proportion of patients experiencing a clinically significant reduction in pain when ketamine was compared to either fentanyl or morphine. There was, however, a clinically significant reduction in pain when fentanyl was compared to morphine. The results of this study suggest that ketamine is not inferior to either fentanyl or morphine for the treatment of traumatic pain in the out-of-hospital setting. Of course, we had some limitations to the study. First, this was a retrospective review. Too few patients had a documented weight, therefore we were unable to calculate a per kilogram dose of ketamine. We had to assume less than 70 milligrams as a, quote, sub-dissociative dose. And further, there was no universal documentation standard among the 887 EMS agencies, so this really limited our assurance of uniform data entry. Thank you.